Thanks, Dr. Rosen, and thank you all for inviting me to speak on 3D tomosynthesis. So we've heard about the scout that helps get the tumor out, and then the different dyes that help to localize the tumor as well too. 3D tomosynthesis is a little bit different technology that really is evaluating the specimen. So I'll just present a little of our data here. These slides I'm going to kind of just quickly go through because I think the other surgeons have done a great job with framing the importance of obtaining clean margins with segmental mastectomy. And we all know the benefits or the advantages of breast conserving therapy compared to mastectomy, so I kind of won't maybe belabor those points, but outcomes are similar, lower complications, hopefully higher patient satisfaction because we can preserve sensation, body image, shorter recovery time. However, as the other surgeons have alluded to, segmental mastectomies still have a problem for all of us. And as has been reported, 20 to 30% of patients historically have had to return to the operating room to obtain clean margins. Hopefully this re-excision rate will improve now that we have the new guidelines which have been discussed, and so hopefully surgeons going back for close margins will hopefully not happen as much, but we will still have some positive margins and patients have to go back to the operating room. And that is a problem for many reasons that we've also discussed. So patient anxiety and disappointment, you know, having to call a patient and tell them you didn't get the tumor all out on the first time is kind of disappointing for us to tell them and for the patient, right? They have to undergo anesthesia again, right? Hematoma risk, infection risk. Maybe now that I have to go back and redo the whole surgery, you know, it's always better the first time. The second time it may not look as good, so, and suboptimal cosmetic outcome, or now you have to do more oncoplastics or get the plastic surgeons to help you if you don't know how to do oncoplastic reconstruction, and then the patient has to take off work again, their family's upset, right? So it's just kind of burdensome. And it also increases healthcare costs, as was alluded to in the other study. Metcalf and those and other people have shown that it increases our healthcare costs, as well as we're all kind of looking for more efficient ways to deliver better and more accurate care. And so how can we become more efficient but do the job better? And so this is one of my I guess I'll show some of my work too. So this is one of my specimens, and so in the operating room, we pretty much use the radioactive seed. However, we have recently started using the Savvy Scout, so I'm excited. But right, with the basic 2D Faxitron imaging, and if I tried to read this, you know, it may project a little bit not as good here on the screen, but you know, is this inferior lateral margin close? Is inferior close? Is medial close? Like, I don't know, so I guess I'll just take additional tissue. At MD Anderson, we have a little bit a different approach for the segmental mastectomy specimens. We don't do cavity shave margins like Anish Chapkar presented in that New England Journal report. So we are a little different in that we try and do more targeted, precise excisions of where the issue or the problem may lie. So we're a little different from what was reported or what may be done out in other areas. And then we've also reviewed the need for an improved methods for detecting margins on a microscopic level. And so the most common approaches are 2D imaging, right? The surgeons, we do pay attention while we operate. I try and pay attention too, so we still palpate, right? We may or may not use frozen sections, but that's very labor intensive, prolongs the OR case. The pathologist may make it more difficult for them to assess the margins. And then the new methods we've all been discussing during this session. Again, we need a method that's accurate, that's surgeon friendly, that we can accurately interpret, easy to use, not resource intensive, and is cost effective. And so 3D tomosynthesis has been used and has been proven valuable for increasing the detection of breast cancers compared to basic digital mammography. However, probably some insurance companies still aren't reimbursing, so sometimes patients still have to have an out-of-pocket charge for it, but right, so it does increase cancer detection rate, and it may have fewer callbacks. And so this is one of my patients who has a little lesion up here on the regular 2D digital imaging on the CCMLO view, but it's really difficult to see. But the tomosynthesis really increases or improves the lesion conspicuity. And so with that knowledge or that background, 3D tomosynthesis has been applied to intraoperative specimen imaging. And so CupTech is outside with their machine, but there are international companies as well too. And so Dr. Kaufman has presented his data at the American Society of Breast Surgeons last year in over 200 segmental mastectomy cases. And it takes about a minute for the film acquisition time. So not a long time. 70% of the lesions were more visible, and his re-excision rate decreased from 16% to 9%. Amar et al., the second one, is a European study, and their technology is a little bit different, but still the same concept of utilizing 3D tomosynthesis for specimen analysis. And the two radiologists reviewed retrospectively, and they used a little bit different definition of negative margins, greater than 1 millimeter for invasive cancers, greater than 5 millimeters for DCIS. So their results may be a little bit different from what we may experience, but 3D tomo had increased sensitivity. And so with that, we have done a small pilot study comparing the ability of 3D tomosynthesis compared to our standard extensive processing for evaluating positive margins for segmental mastectomy specimens. And so again, at MD Anderson, we're a little different. We have a lot of patients come from other states, and a lot of patients come from international, and so it's even more of a burden for those patients to have to come back to MD Anderson. So we're also fortunate to have a lot of specialists. So we have a lot of breast mammographers and a lot of breast pathologists like other academic centers. And so for our segmental mastectomy, so I'm going to use this kind of flow diagram throughout the study because it can get a little complicated. So for our basic approach, so we would do an intact specimen, an intact lumpectomy 2D image, and then the pathologist would actually slice that specimen. They would grossly palpate and do frozen sections every once in a while if needed, but that's not a standard approach. And then, kind of as a poor man's test for 3D imaging, we would take a specimen x-ray of the sliced images. And it's a little hard to see, but the specimen, is labeled medial, superior, lateral, inferior, and those same margins are labeled on the sliced specimen. So now you can see still, lateral, superior, but posterior is also oriented, and then superior. You also know, your posterior and your anterior margins as well too, because on your intact specimen, it's just a kind of a big blob of tissue, and you don't know if that calcification is anterior or posteriorly or where it is. And so by slicing the specimen, you can then really evaluate all of the 6 margins throughout the entire specimen. So it's sort of our poor man's kind of way of extensively evaluating the specimen. And then the mammographer and the pathologist, the mammographer reads these 2 films, and then they both call back into the room, and they'll tell the surgeon, hey, you look good, or hey, you need to take a little bit more tissue, lateral, posteriorly. And so the surgeon excises additional tissue, and so the final pathology, the final margin status is based on the initial lumpectomy specimen, as well as the additional excised tissue, and that gives us the final margin status. For this study, we also obtained tomosynthesis images of the intact specimen, and those images were retrospectively reviewed by the breast radiologist. I think I missed a slide. This is the slide. I'm sorry. I just want to show you how the technology works. Can you all play the video for me? And so the CupTech machine, so it takes an initial picture of the specimen, And then this is an initial capture of the specimen, high resolution. And then the tomosynthesis, the 3D tomosynthesis, now it goes through the specimen in 1 millimeter increments. And you can start to see the biopsy clip. You can see the seed. And now it's going back up. And so the density is here. There's actually some calcifications in this area as well too. There's a calcification right there. There's a calcification over here. And so at 1 millimeter intervals, the surgeon is now able to have improved resolution of the density, calcifications, and to be able to look at the margins. So that's kind of the technology that the 3D tomosynthesis is providing compared to our manually slicing and doing it kind of the poor man's way. Okay, our patient characteristics, median age was 60 years. Only 12 patients received preoperative therapy. The study included 98 patients that had 99 segmental mastectomy, so about 100 cases. Most of those cases were invasive ductal cases, and most of them were T1 and T2 lesions. And for our standard extensive processing, so when there again were 99 specimens, our standard extensive processing often overcalled and would tell the surgeon, yep, you need to size additional tissue in about 75% of the cases. So they always call back into the room and tell us to take more. And we listen, we take more, but then only 16% of those additional excised tissue actually has malignancy in them. So the false negative, so we're taking, 50 additional cases or 60 additional cases had unnecessary additional tissue. For the initial lumpectomy, only 14 specimens had tumor at ink. And our pathologists and mammographers, they were able to identify all of those 14 specimens, but they did tell us to take additional tissue unnecessarily. When we took all of the extra tissue, the final margin status, we had 6 cases that had tumor at ink, so which is about a 6% positive margin rate. Of those 6 cases, our SEP, our standard processing, still did not identify 3 cases that had positive margins. So some patients still, obviously have to go back to the operating room. For 3D tomosynthesis, so 3D tomosynthesis read 32 specimens as having tumor at ink compared to 74 about our guys really overcalling things. The tomosynthesis identified 13 of the 14 cases that actually had tumor at ink. The one case that it missed was only a little bit of focal DCIS, so it was very minimal disease. Of the cases that had malignancy in the additional excised tissue, 16 cases, tomosynthesis identified 11 of those cases. Again, the 5 that it missed were very small foci of disease that radiation likely would have controlled for. And then 6 cases after we did everything, 6 cases had tumor at ink, and then tomosynthesis did not identify 2 of their margins compared to it actually identified a case that SEP actually missed, which is kind of interesting. This slide may not project very well, but the 6 cases that had final positive margins, so one case was extensive DCIS, so again, DCIS being a major sort of problem. This case was a small invasive ductal with extensive DCIS, and then positive margins, if it's in red, that means both our processing and tomosynthesis did not identify. So this patient had a positive lateral anterior margin, which our standard processing did not identify. It called something else. It actually called some close margins, and digital tomosynthesis did not identify it either. So actually we had to take that patient back to the operating room. But when we did, she underwent a re-excision, and that lateral anterior margin was actually negative. So our standard processing and digital tomosynthesis did not identify 2 cases. This case, extensive DCIS, a medial margin was positive. The patient went back for re-excision, and it just showed focal ADH. There's one case that digital tomosynthesis actually identified, so it identified a superior, medial, and inferior margins, but we did not identify that medial margin in the operating room. The medial margin was positive, so I actually had to take that patient back to the operating room, but the medial margin only showed focal DCIS. So really in both instances with both technologies, very minimal disease was actually missed. So both actually do a really good job. The problem is our extensive processing takes about 15 to 30 minutes on a good day. Whereas this takes like 60 seconds. So, right, so we are trying to improve our workflow efficiency to be able to do more cases and not have patients under anesthesia that amount of time while we're waiting for pathology and mammography to do this whole laborious physical process that a new technology could provide. And so this is sort of comparing, could the two technologies identify if a case had a positive margin, and then could it also identify the actual specific positive margin. So again, 14 lumpectomy specimens, 14 out of 99. If you just do a lumpectomy like a lot of hospitals do, and you do your 2D FACS your 2D imaging, and then we had a 14% positive margin. Tomosynthesis detected 13. It missed, like I said, the case had a little focal DCIS. SEP way overinterpreted those cases, so we took a lot of tissue when we didn't need to. So tomosynthesis was more specific compared to our standard processing was only 28% sensitive, and this is actually statistically significant. They are both really sensitive, and that's actually not statistically significant. And the false negative rate, again, is just one case that was missed out of the 99. For the lumpectomy, the 14 initial lumpectomy specimens, they had 19 margins positive amongst them. Most cases just had one positive margin, but a couple of cases had multiple positive margins for a total of 19 positive margins. Our standard processing detected 16 of them, and the surgeons were able to go, and take more tissue. Tomo detected 14 of them. And so for margins, out of 99 cases, if there's 6 sides, that's about 590 margins. So these two differences actually, I don't think, are going to be statistically significant. So I put preliminary data. We're still working with our statistician to run the final p-values and stats on this. But both of them are DBT is more specific, but both are pretty sensitive. And then the 6 final cases that had positive margins, SEP detected 4 of their 7 positive margins, and DBT actually detected 5. Again, SEP missed 1, invasive cancer, where we had to go back and excise additional tissue. So in conclusion, right, tomosynthesis is very surgeon-friendly, quick acquisition time of about 60 seconds, which will help a lot of places that, if you're trying to do frozen sections or do things like we're manually doing. It's portable. The machine, I think, was out there this morning. It may be gone now. It actually has the ability to, it has a CAD-assisted, a computer-assisted capacity to detect calcification. So as a surgeon, if we're worried about missing some little calcification, it will actually highlight that for you and tell you which slice, and so that you can actually go back into the lumpectomy cavity and excise appropriate tissue. It has improved density visibility compared to 2D imaging, accurate margin evaluation, and it pretty much, the surgeon can independently assess the tissue without the need of the mammographer or a pathologist. And so thanks for your attention. I just want to, I forgot to say I have no financial disclosures, and I just want to thank my collaborators, Dr. Kerr, and our breast imagers and our breast pathologists who helped with reading, and our statisticians who helped with performing the study. Thank you.